I'll see it because I see so many guys that play tennis, and your carpal bones just feel like a big bony ball when they get this arthritis in their hand. Really interesting. Where I'm used to going through and assessing the motion of the carpal bones, and you get your hand on this wrist, and it feels like all these carpal bones don't have their individuality. They feel like a big bony mess. And then, of course, you're going to see this loss of range of motion. Typically, like we talked about in the article, these notes are generally from the article. If you think about the bones of the distal carpal row, which can be the hamate, capitate, trapezoid, trapezium, these bones are really tightly bound, via strong ligaments, as is the whole wrist. But, they essentially function as a unit, is the idea. So you have this distal row that's much more strongly bound than the proximal row, and that this is essentially works as a functional unit. You'll get in there as you palpate this, you're going to find that you're going to have a lot more mobility in the proximal carpal row if you take your lunate on your scaphoid or your lunate on your tricretrum versus your capitate on your hamate.
It's also
Trapezoid.
going to be real quick, Dave. It's also going to
Go
be
for it.
more, you're also going to more notably feel more motion going from distal to proximal than you will in the sagittal plane movements. So trying to move the trapezoid on the capitate, for instance, is going to feel a lot stiffer than trying to move the scaphoid on the capitate.
Yeah, as I said, what's nice about introducing this now is the ability to play with your own wrist a little bit, just poke around with these things ahead of class time, just to get a little bit of tactile sense, even if you don't have a complete mental picture of it. It's just a nice way to kind of tie these things in.
Eric, could you repeat that one more time about what you just said about the trapezoid and the scaphoid?
Yeah, so if you're looking at the image here on the screen, the proximal row, the scaphoid, lunate, and triquetrum, you're going to feel more mobility between the proximal and distal rows than you will in the sagittal plane movements, like the hamate against the capitate. So bones that are adjacent left to right are going to feel stiffer than bones that are adjacent distal to proximal or proximal to distal.
Perfect. Thank you.
Yeah. In general, what that's going to mean is subluxations are going to be more rare on those sagittal plane movements, right? So hamate on capitate, et cetera, those sort of things are going to be a little bit less common as far as subluxations will occur. And you're more likely to get capsular lesions of distal row on proximal row or vice versa, because there's more mobility in that joint, more likely to bang into those soft tissue restraints.
Any other questions at this point?
DCR, you're meaning distal carpal row, right, Dave?
Yes.
DCR and PCR, just so they know.
Yeah, proximal. Think of proximal carpal row as being the red ones, and the distal carpal row be the orange ones going forward.
Yeah.
And again,
the one other exception that we have to consider is that trapezium on the trapezoid. It's as far as mobility goes, that's going to have some of the most because of its articulation with the thumb. It's actually not really in the same plane as the other joints are. It's a little more oblique. So if we look at our hand like this, my trapezoid is going to be here. Trapezium is going to be here. So it's offset with the rest of the row. So it's going to be more of this oblique angle as far as its movement. And the joint surface is going to be a little more variable. It's going to have a little more curvature to it. So it's going to be more kind of curvilinear as far as its articulation, as opposed to something more planar. So the trapezium, relatively, because we were talking about the distal row being a stiffer set of joints, the trapezium is a little bit kind of off that beaten path. It's going to maintain a lot more mobility.
Yeah, I think it's a fair statement to bring up there because there's a whole section we're going to do on how to treat that joint and a little bit of the stiffness. But yeah, it's a good point to bring up here, just so you don't get locked in that it's the entire carpal row is that way. But that section can move differently.
Yep. Especially when we start talking about clothes packing and things like that.
Again, as a general rule, kind of, in this article, and it's not hard and fast, but you think of, okay, there's appreciable motion that we're gonna have between the radius and the proximal carpal row, and you get the largest amount of motion there. There is motion, we have less motion between the proximal carpal row and the distal carpal row. And basically, they're talking about, very no motion between the distal carpal row and the metacarpals, as far as them being stiff. But again, we're talking probably, 2 through 5 we're referring in here, not so much, I would say, that when we're talking about the thumb. Is that fair, Eric?
Yep, certainly.
You do say that, you can come up with the impression, okay, they're all the same, but the thumb is different when we talk about this. We're getting to that point where, okay, there's no motion. Definitely different when we're talking about the thumb, and that those joints generally kind of move together. There's a little bit of a glide there that you see occasionally. I mean, I'm trying to think of situations where I've manipulated that joint once or twice at the distal row and the metacarpal, had it be helpful. So I do work in that area. It's just way less common than the work I do in the proximal to distal carpal row or the trap on trap that Eric is talking about.
Yeah,
And
I see a fair amount of thumb issues. Kind of a bit of a pet project for me because my mother has really arthritic thumbs, so I see a ton of patients that have had to deal with that sort of stuff. So that's just kind of the nature of some of the population that I've built up in my practice and whatnot. But it's just an interesting joint right there, that trapezium on trapezoid, because basically what it doesn't close pack at all. That trapezium on trapezoid joint doesn't close pack, and that's so that when we have our wrist in full extension, which should lock up everything here in the wrist, it's so that we can still move our thumb in that position. If it were to lock up, we'd get our hand like this and our thumb wouldn't move. All we'd be able to do is this sort of thing. So, which isn't very functional for a species that has functional opposition of the hand. But we'll talk more about that as we get to the class. It's not something that we need to get real focused in on right now.
Yeah, at that point too, I thought it was worth mentioning just bring in some of the notes on TFCC. They didn't go into this in the article as much, but it's just not, it's a good one to know because it's hard to talk about the proximal row without saying TFCC. Again, for the notes, it's going to cushion and transmit forces through the lunate triquetrum where it's placed. Repetitive loading, supination, pronation may generate tears or abrasion. Where I'll get it is, again, tennis and people who racket sports, it's a lot of pronation, so a lot of pronation motion with that, and there's a lot of radial ulnar deviation. And common one I'll see, if the hips and thorax aren't moving well over the shoulder, then generally they're going to generate force at the wrist. So maybe the wrist that I will see in this setting, okay, they have a wrist problem, but it is a full body mechanical problem that ends up beating up the wrist. So I see this probably more than the average person might, but the most common thing I'll see is that the problem itself is coming from somewhere else. And the wrist is kind of the thing at the very end getting beat up. Instead of it's more like the handle instead of the whip. If you're generating all the speed with the end of the whip, then it's going to be a problem joint. If you think about it that way, where I'm generating speed, momentum from hips, thorax, shoulder, and the wrist takes a whole lot less stress. Same is true for tennis elbow and also anterior shoulder stresses.
I kind of like that analogy, actually. I'd never heard that one before.
And again, you can think of this as functionally, again, it's going to distal ends, the radius ulna, it's going to bind them together, provide a surface for the ulnar head to move under the carpals for pronation, supination, weight-bearing surface of the lunate, triquetral force, and energy transfer. And it's something that came up in the article too, which went into more detail, which I thought was interesting, is that, if you think about when we're going to do like a push-up or in a wrist in full extension or any position, 80% of the weight roughly is transmitted through the radius. 20% is going through the TFCC or the ulna as we load in there. It kind of makes sense when you start to think about your fracture patterns of a fallen and outstretched hand where that force is being transmitted. And, we won't go into detail on it, but that load is then transferred through the interosseous membrane to the ulna that's coming in. And that's how that force transfer unit kind of works with an interosseous membrane. So there can be some interosseous membrane injuries are rare, but it can happen. But it's an interesting thing to think about because you get that force coming through. You have distal radial fractures, carpal bone fractures, have radial head dislocations or radial head subluxations that can occur because that force being transmitted completely through the radius, maybe not transferred then through the interosseous membrane to the ulna. And that's where those forces kind of build up.
One of the more common things that I see is it talks about it right here. So that fourth paragraph, whatever we'll call it, where it talks about dependent on carpal alignment, ligamentous integrity, and ulnar variance. So that's that difference in deviation, distal to proximal of the radius on the ulna. So if you're looking at the image here, what we'll often see is we'll see a deviation of the radius that'll move distally into the wrist. It's most commonly caused by some sort of radial head problem or some sort of elbow issue. Now that can be a cascading problem that comes from the shoulder, comes from the thorax, or the shoulder girdle. Any of those sort of things can kind of force those issues to come down the limb. But that's one of the more common problems that we'll notice that'll end up creating issues within the carpal alignment and that ligamentous integrity. Because if you think about it, that radius starts to push into the carpals, what's going to happen? Scaphoid's going to have to get out of the way, right? So it's going to have to move itself somewhere. The lunate's going to create a bit of a tilt. We're going to increase the tension on that, the face portion of the, basically that radioulnar portion of the TFCC. It's going to alter the loads mechanisms that go through the disc itself. So that interosseous membrane is going to increase the amount of tension there. So all kinds of crazy things can start to happen in the wrist. Plus, it's going to force the radius to take up almost 100% of the amount of weight-bearing load. If we have some sort of fallen outstretched hand, or we're pushing on something, or lifting something of that sort of nature, because all of a sudden the ulna is no longer approximated with the proximal carpal row. So definitely a big issue, but that's what that ulnar variance is talking about there.
TFCC is some common, and again, see this one a lot when somebody has a wrist injury. The premise I see it too is like for ulnar deviation motion, we're going to get into ulnar radio deviation, movements here in a little bit, and kind of in a bigger, broader view. But we'll look at how, again, this disc can be the victim of just how if that motion gets overemphasized when I'm doing, certainly in sports or movement, or a lack of mobility somewhere above elbow, shoulder, and we start to make it up in the wrist. And that's when you'll see some of these ligament degenerative changes or irritations occur. In this article, they talked a lot about, they went into like fanning and folding of the wrist. They talk more about pronation, supination, where in some of our notes, we may talk about internally and externally. I know all this gets confusing. So today, what we want to get to understand is, if you take your hand, kind of flex your wrist and kind of bring your hand in, what you're noticing in that first image is you're going to have a folding moment of the hand. Carpal bones kind of fold toward the midline. You extend your wrist, bring it back. There, that's they refer to as the fanning moment of the wrist. Comparing this to what they talked about here is, they're talking about the proximal bones here, flexing during global wrist flexion and extending during global wrist extension. And they'll talk here about the scaphoid's tendency to supinate and the lunate to pronate. In some of the notes you may see, and Eric, you can kind of describe if you describe this at all, or if you describe it anyway. In some of the notes from our coursework, you'll talk about the scaphoid and trapezii internally rotating, kind of like what we talked about around the foot moving around the second, metatarsal. And
yeah, it's almost exactly the same thing.
Go ahead.
The thing that you have to take into consideration here is the position that the body has to be in when we're doing these movements. These movements are named based off of the arm and wrist being in the anatomical position, right? So standing, hands, palms facing forward out to your sides, that's the anatomical position, right? What we would look at if we saw the body standing in an anatomy text. So when we look at that, if we're in that position, right? So I don't have a ton of room in this little office here, but if I'm standing like this and I fold my hand like that, so I create wrist flexion, the scaphoid and the trapezii are going to internally rotate, meaning they're going to rotate toward the midline of my body. If I do that same motion here, the hamate and the triquetrum, as I produce this movement, are going to rotate externally away from the midline of my body. So we just have to kind of consider that those motions are being named after the position of the hand in that anatomical position. And it tends to be a little more easy to think about. And then extension in that same position, or the fanning component of that, is just the reverse, right? So if I go into extension here, this is going to rotate this way, this is going to rotate that way. So external rotation for the trapezii and the scaphoid, and then internal rotation for the triquetrum and the hamate in that anatomical position with my arm out to the side like that, palm facing forward. That's where those internal rotation and external rotation moments are generated from, is that sort of position. I tend to think that's a little easier than thinking about it based on pronation, supination.
Yeah, because you can get into a lot more detail once you get the ligament tears. But I think the fanning and folding, and then that next layer in is that internal rotation, external rotation is kind of the language you're going to use in class. So it's a good way to just start thinking about it and just kind of, again, looking at your own hand as it folds in here. Because that fanning and folding mechanism is something that, even if it's like the elbow patient, I mean, I'll screen through the wrists pretty much in everyone who has an elbow. I'll work my way through it in most upper quarter patients.
Yep. Yeah, you have to.
It gives you information about what's going on, what may be the potential stress at the extensor flexor tendons going on, where do I have a problem here, what's going on with my grip strength. So you can see a lot of things. And here I pulled out just a quick image of that, if we're looking at just quickly that fanning and folding mechanism. So if you're a patient rolling in at 2 o'clock here, and or it's 1 o'clock for you, you can just basically take their hand through this fanning and folding mechanism and feel, okay, maybe you start with your, right there. It looks like the thumb is probably on the triquetrum lunate line and lunate scaphoid line there. And you can kind of feel the fanning and folding of the wrist at opening and closing. Bring somebody into flexion, and I have them in flexion, and they're there, and then I come up into extension, and I don't feel that opening, let's say, of the scaphoid or trapezium. And that's going to immediately just going to do with the joint glide that you'll learn in the class to see, okay, do I have a problem with reposition or that external that glide of that joint to come out? Because at that point it's going, we'll call that internal, and it won't go external. But it's that fanning and folding, that opening and closing. You just get a few patients between now and then, feel some wrists, feel them open and close, and then we can layer on more detail as we get in the course. But just get your hands and try and poke around these bones, get a sense of the normal feel, and focus on fanning and folding for now. We'll be in good shape. Let me see out here. Hey, Chris, you looking at any wrists?
Yeah, kind of a good number.
What are you saying usually? How do you look at the wrist? Is carpal mobility something you typically assess?
I've never really thought of it, but there are some where I do find myself just kind of seeing how they glide.
Yeah, it's just you start to move things around because you get a kind of innate sense of what you feel is normal. What is it? Anyone else checking carpal glides out here? Like to talk about it?
I do.
Ariel.
I do it a lot. I see a lot of wrists.
Cool. What do you see?
Well, I mean, I look at a lot of wrists because I see a lot of elbows, I see a lot of shoulders, and wrists. You kind of have to look at a wrist when you're looking at an elbow, just because of where all the musculature attaches, and that sort of stuff. So, but yeah, I mean, I like I was saying earlier, I think the biggest issue that I see typically is something in the elbow that's affecting radial head position. That's going to affect the kind of distal to proximal alignment of that radius and the resulting alignment of the carpals. But the wrist is fun to treat for me because it's one of those areas of the body when you find somebody that just has a simple subluxation, they're walking out their front door and they slip and they grab onto the railing on the stairs or something like that, or even if they fall backward and they kind of land on that extended wrist, you can get a real simple subluxation from those sort of things. And people get all kinds of irritations around the wrist, whether it's on the palmar side, it's along the thumb, it's on the dorsal side, or kind of that radial, kind of radial joint line right around this area here. It's real easy to fix that stuff. If you can find a simple subluxation, just to do a simple whip manipulation and fix it, you look like a magician to your patients when they come in and see you for that sort of stuff. Because a lot of times they'll bum around with that stuff for months, and they'll be avoiding activities. They'll be avoiding playing things like tennis or swinging a golf club, lifting weights. the number of problems that people get are endless. People that work on computers, they get miserable with that sort of stuff because they end up with their wrists kind of cocked back like that. And it ends up being a big problem. So you come in and you're just like, well, you just subluxed your scaphoid here. It's not that big of a deal. And you just do kind of a just like that, and it pops right back into that little divot on the end of the radius, and they're just like, oh, yeah, everything's great. So at that point, it makes you seem like you really know what you're talking about when you can treat a wrist effectively. But I do think there's a lot of PTs that tend to shy away from wrists because of the mechanics seem a little muddled. The anatomy is always one of those things we need mnemonics to remember and things like that. And a lot of PTs have hand specialists or OTs in their clinics, and so they kind of get passed off, or the people doing intakes don't even think to send one of the therapists the hand or wrist patients because there's somebody in the clinic that's their job is to deal with that. So I think it's a good thing for everybody to know, just because when you look at an elbow, you really can't go through and do a good screen on an elbow unless you also look at the wrist. Just because there's too much of an interconnected functionality between the two regions. So I think it's a good place for us to really, really learn things. The other thing in these courses, I think the wrist might be the single best region of the body for us to discuss open pack versus closed pack, or loose pack versus closed pack, just because of how we do mobility testing and stability testing in the wrist. Literally, not a single thing changes from when we're doing mobility testing to stability testing, except for the position of the wrist. So to do mobility testing, we need the wrist in a loose pack position. So we keep the wrist in flexion. To do stability testing, we need it in a closed pack position. So we move it into extension where it's closed packed. The movements, the inner carpal movements is exactly the same. So we make these things seem I think the general perception among physical therapists is that the wrist is very complex and we need to have specialists in order to handle this sort of stuff. Hopefully by the end of this class, guys, hopefully you guys will be specialists on this sort of thing. You'll understand the mechanics real well, and you'll realize that a lot of the things that we get kind of concerned with the wrist it's not as complicated as we think. Sometimes it's just a matter of changing the hand position from one spot to the other.
Yeah, that's what it is. Most hand therapists aren't going to understand manipulating carpal bones. So if you have a carpal subluxation, then it's going to get completely missed, or there's a carpal restriction. I've seen when people see hand therapists, then they come by me and I manipulate something really quick, because I've had a fracture for 5 months post fracture. Cleaning these things up pretty quick because these bones get rather stiff.
Oh yeah.
Being able to work the biomechanics of this is hugely valuable. Dan, you seen any carpal tunnel patients out there?
We've got all our OTs or CHTs that treat most of that. So I hate to say I defer most of it to them.
Got it. Do
I'm
they see
seeing,
oh, go ahead.
sorry.
No,
I'm
go
seeing
for it.
like a bilateral, like hand and wrist like numbness and just a fatigue thing. And I'm treating the neck and the wrist because I think it's from like prolonged gripping from dictation and typing.
Mhm.
And so I'm treating the neck and the wrist. And it's definitely more peripheral in terms of like the numbness stuff, but it is
Okay.
bilateral.
Yeah, I mean, do you look at the proximal row, or the carpal mobility there?
I just in the last week started moving the scaphoid because on
good.
the right side it's worse
Mhm.
because she is not like properly trained in typing, but as a doctor, so she'll sit and like she fully extends her wrist and then like brings her thumb and rests it on the back of the keyboard. I can. So she's like extending her wrist and then like resting her thumb and then like pigeon typing or whatever, chicken typing with both hands. And so she's like this for extended period of time. And then she'll try to dictate and you have to hold it the whole time.
Mhm.
And so she has to hold and maintain that contraction. And so both of her wrists are, and the extensors and the flexors are just incredibly hypertonic and tight. And then she gets like prolonged numbness and can't like brush her hair.
Yeah, I mean, it's probably good to work in the scaphoid, and that's where if you're just looking at some of the, like, if you want to jump ahead, is looking at some of the trapple and trap mobility technique. And then even just kind of looking at I would look at the lunate and tricretrum, just look at that proximal row mobility. Much like you're looking at, okay, where does the transverse ligament attach? coming across the palmar and really working these bones and having stiffness, almost that folded position. Because as her finger here, she brings her thumb down, almost that flexed and folded position. That's actually the fanning and folding here in this one is reversed in the image that I pulled out of Gail's slides, isn't it?
Way to go, Dave.
Hmm?
Way to go.
Yeah, great. I copied it. I didn't pay attention to the labels on it, but the labels look like they're reversed.
What I'm kind of curious, where is the numbness in this patient's hand? Is it the whole hand?
No, it's mostly the thumb area,
Mhm.
and then like it will come up into her wrist.
Okay. Well, that's
It's-
not real carpal tunnel then.
No, it's
Mhm.
not carpal tunnel. I'm just
Yeah.
'Cause true carpal
Yeah.
tunnel only gives you numbness in the tip and the three fingers.
no, it's not. I'm not treating it as carpal tunnel. But she just has this numbness. It's just a hand patient I'm seeing. That's all.
Yeah, no, that's good.
Yeah.
It's good that you're looking at the neck because something that occurs bilaterally, kind of symmetrically at the same time, the odds of her getting the exact same problem on both
Yeah.
hands at the same time are
And that's
Yeah.
what I told her. And so she was like separately having shoulder pain and numbness at night. And so that's cleared up with the neck stuff. But this seems to be more like just because of the like tightness through here, and the hypergenicity on like her wrist extensors and flexors and
Yeah.
but yeah, and I mean it's definitely part of her neck too, because there's a ton of like thoracic. I've been treating the upper thoracic too, just like restrictions through there.
it's good. Excellent.
Yeah, so you'll like this. I jump ahead a little bit. Take a look at some of those things if you like to work through the trapple and trap and some of the mobility stuff there. See if that gives you a little bit of a bump. So you find something restricted there. As Eric said, sometimes it's like you look like a rock star doing a trapple and trap minute.
It's easy to look at too, because so when you want to look at trap on trap, trapezium on trapezoid, it's these two motions. So you want to try and have them make an L shape with both thumbs, and what you'll see something like this, where this one won't extend real well. So you want to be able to see symmetrical movement here, and you want to be able to see symmetrical movement reaching across toward the base of the fifth digit there, right? So something like that. And what you'll see is somebody that will get like this, where they can't quite get that thumb all the way over there. So there's a gap in between where you should be able to get that flat like this. So that'll tell you if they can't get to here, that it's a limitation of dorsal glide of the trapezium on the trapezoid. And if they can't get to here, then it's a limitation of palmar glide of the trapezium on the trapezoid. Pretty simple. Then you just grab one, move the other. A little more to that, but that's a good place for you to start.
Yeah. And so, Jan, as you start to think about it, you're a regional guy out there in the Badlands. So you start to take a look at this, then chat with your OTs when this is done. Because you may find what you're taking from this course, whether after this one or one of the future ones, is that you'll find that a lot of your OTs don't know these techniques and they would be great value to them. As you do this, Jan, just put that in the back of your mind, because I know you're traveling around lots of these different clinics. So as you look at these things, get a sense of what your OTs are doing, see if there's something you can bring to them.
No doubt. I mean, I so many of these classes, I'm sitting there going, all right, this therapist needs this, or
Yeah.
just kind of bombarding. And then even with our hand therapists that we have that are certified, the levels of knowledge, they're all certified, but the levels of knowledge and treatment are completely different as well. So there's always ways that everybody can improve.
Yeah. And again, as I talked about before, just let me know if you need resources and stuff. Put that in the back of your mind. It's a good thing to start thinking about now as you do it. Like, you don't need to be a pro right now, but it'd be a good skill for you to have. So I think it'd be a lot to bring to your people. Ooh, ulnar radial deviation. Yeah, we can chat a little bit about the biomechanics as we get into this, but again, the proximal carpal row is going to move in combination with the distal carpal row during the wrist flexion extension. And again, there's a bit of that one doesn't make much sense. The parts here, we're talking ulnar deviation, radial deviation a little differently. In kind of the way I learned it a bit, we'll look at some future diagrams, is that you get a bit of a separation between, if you feel dorsally on your wrist, between the lunate and the capitate as you go into flexion. So there's a bit more pivoting, but the majority of that motion at the end is going to be occurring at the proximal row. And going into extension, I think the kind of close back with the mid carpal row a little earlier, as well. So there's less maybe motion at that mid-carpal row is how I initially had learned it going into here. So it's always nice to read these articles because coming from medical journals, they sometimes have a little different spin on what we learn coming out of the manual therapy world. Because I feel that wrist, flex, you can kind of feel the position of the lunate. You can almost feel like a little space in between the lunate and capitate. If I kind of flex my wrist this way, they come back, they're going to approximate. And that, as soon as they lock up, then that glide is going to go into the proximal row. How do you think about flexion and extension, Eric?
Yeah, I mean, I look at it as almost like a what's the word that I'm looking for? Almost like a compression look type of movement, where we'll get this proximal row. So as we move into extension, what should happen to the proximal row is it should glide palmarly, right? And then the distal row should go more dorsally. But when we're looking at it in combination, is almost like we're kind of squeezing these two components together. And all we need to do is make some room. So the proximal row will go down this way, distal row will go up this way. And so things will kind of compress down, almost like we're shortening the length of the arm going into the hand in that sort of situation. So it's a bit of a unique biomechanical function when we look at that sort of thing.
But yeah, a lot of what I look at too is, I'm not, because they're so stiff, unless they've been in a cast or it's been some trauma, a lot of the motion I'm assessing is going to be, proximal row in between proximal row and distal row. Not so much I'm looking at distal row intercarpal mobility as much, or again, distal row on the metacarpals. My focus is generally going to be in that row there. Most of your sprains, your falling the outstretched hand, your torn ligaments that create instabilities, what they mostly look at is those ligaments between like scaphoid and lunate and triquetrum. Your common, your instability tear.
For sure.
Those bones, and when you have that, what'll happen is okay, if they don't have significant pain, many times what you're going to feel is that as you go into that extension, one of those bones is not going to glide palmarly. It's going to stick back a little bit and it's going to move separately. All of a sudden, there's not this congruent motion. So comparing the proximal row, let's say the triquetrum within lunate on the left hand and comparing it to the right hand, it's like, is that motion symmetric? Is it symmetric to the other hand? Or do all of a sudden I can start to get into that closed pack position and that one bone is kind of colliding or staying posteriorly? That's commonly what I'll find if there's a carpal row, mild instability. Usually a biker who's wrecked. Come on.
Yep. And they're generally easy to find because all you have to do is go into the inner carpal space with like a pencil eraser, for instance. So you grab something kind of like this, where it's got that soft thing on the top, and you just put it in between the two bones, kind of put a little pressure in between those two. And as soon as you find the one that's sore, you know where the dysfunctional joint is, depending on which two bones are affected. If it's scaphoid on lunate or lunate on triquetrum, or I guess it'd technically be triquetrum on lunate if you're trying to think about it that way. That central column doesn't move quite as much. But yeah, that's an easy way to kind of look at it and say like, well, okay, so this is where my dysfunction is in between these two mobile articular segments. And then it's all about, you can focus in on what the either is, is there an immobility, a hypomobility, subluxation or capsular lesion, something like that, or is it unstable? Have they kind of banged this thing up to the point now where it's real sloppy and unstable and moving around too much? So it can kind of guide your treatment pretty easily with that sort of thing too. Sometimes those easy, sometimes we want to make things real complicated and we want to do some fancy stress test when sometimes the palpation is the easiest way to determine that stuff.
Racer's pretty cool. I never thought of that. Spot.
I learned that from Jim. Jim's just like, yeah, just get your finger in between. Whichever one's most sore is the one that's going to be problematic. Like, why didn't I think of that?
Yeah, because you're right. Most of the stability tests are all, basically, stability tests. It's like, okay, and dorsal volar shear test. Just to give them fancy names, but they're all kind of the same thing.
Yep.
Cool thing is, proximal row, I thought was kind of like the talus when they talked about, is that there's really no muscles acting on the proximal carpal row. All the tendons that influence wrist motion insert distally. And proximal carpal row depends entirely on mechanical forces in their surrounding articulations. And it's funny when you thought about it, it's like, started to think about it. Could I think of one that did it? I thought something that's funny. It's kind of knew it, but I didn't really sink into my brain that, oh, okay. So I thought about kind of like a talus.
Yeah.
Totally
Or
different
the,
in
or
smooth
the
patterns.
cuboid even. Cuboid's kind of the
Yep.
same way.
Mm-hmm.
It really depends on stability, or stability of the cuboid relies on that close packing, right? That anterior to posterior pressure, kind of closing the calcaneus and the metatarsals around it and compressing it. It's the same thing with most of the carpus, is that we rely on that muscular force kind of compressing everything around it. So if it's mechanically, if it's not moving properly, then we're going to have troubles. We're going to have troubles getting that kind of articular stability. And or two, if we have instability where something's too loose, we're gonna have a hard time kind of close packing, that sort of thing. So it makes a lot of sense to act the same way as the foot, because they are analogs to each other.
Carpal ligaments. I'm not brave enough to get into this on a Zoom call, and I think I would lose absolutely everybody. But best thing to think about is a complex ligamentous system. Really designed to create a lot of stability. There's extrinsic ligaments and there's intrinsic ligaments that influence this. So there's a lot of things. There's ligaments which are going across multiple segments. There are ligaments which are going from joint to joint, depending on the direction. I would prefer not to get into this in great detail at risk of losing everyone and being hunted down by Teresa.
Yeah. We'll talk a little bit about it in anatomy during the course, but I'm really only going to highlight a couple of ones that tend to be problematic. Ones that tend to produce more instability and things like that. So don't get too concerned about those things.
Yeah. Again, this diagram I thought was interesting as we went through there. I don't know how much value. It's like I can hold my hand out here, and if I think about holding my left wrist out there, and again, now my ulna's, on the right, my radius is on the left, and I can think about just the different actions and lines to pull, from where these muscles are. And it's obvious to us because it's what happens in our wrist, but that the extensor carpi radialis longus is going to pull that way. The extensor carpi radialis brevis, they're in that line to do these different wrist motions. So we get a sense of what is able to pull me in different directions. And it's like the wrist clock. It is one of the terms. So just a nice way to kind of think of it in that terms of which direction I'm going in, which muscles, where do they lie, and that vector of pull that they're going to create. Because many times it's going to be, you're going to look at something that's going to do extension and ulnar deviation, depending on its orientation, or extension or flexion, ulnar deviation. What's going to give me those component motions around the wrist clock? So if you move your wrist in a certain direction, you can think about, okay, hey, what muscle most likely gives me this vector? And that helps in problem solving. If somebody has an overuse injury, or you're seeing repetitive strain injury, pretty quickly you look at the movement pattern that they need to do and just get a sense of what is overactive or what is dysfunctional in the pattern. Where is it going? And it should closely correspond to this wrist directional pattern. And then many times what I need to do is change the pattern. I mean, classic one would be, think of a extensor tendinopathy. What's the most common thing? Okay, quiz time. Kevin, what's the most common thing guys complain of when they have wrist extensor tendinopathy?
Oh, maybe lateral elbow pain.
Okay, what's the second most? They go to beat their buddies, and what do? They're out. They're going to go watch Iowa get crushed by Michigan. But before that all happens,
They have difficulty
curls,
drinking their
Are you
beer.
thinking 12-ounce curls? Is that what you're referring
Yeah,
to?
12-ounce curls. That, or they're shaking their buddy's hand. So most of the guys I see.
How injured do you have to be to have difficulty drinking beer?
Yeah.
Oh boy,
I'm offended by that.
That sounds like a real problem.
Yeah, they're probably just.
And I don't think anyone's going to report that to me in clinic.
Man, you better be in a body cast for that one.
But shaking hands is the common thing I see. I see guys and they come in, and that's the one thing they'll talk about. It's like, boy, somebody goes to shake my hand and it's just like, I'm dying. I don't even want to do it. It's just a terrible experience. It's funny how widely emotional it is for these guys in these corporate jobs. What I teach them to do is change this vector. I take them into basically what's going to be flexor carpi ulnaris. And I have them quickly flex their wrist subtly as they go to engage. So it's not an extensor moment, it's a flexor moment. So I'm looking at this clock, and what I'm doing with somebody who's a gripping problem, I think about, how do I flip the clock? and take them into a different direction. Now those guys can do that. If the instantaneous moment of shaking a hand becomes a flexion ulnar deviation, just subtle and people don't notice it, changes the pain pattern completely. They don't get pain at all. But and then I need to take it into movement and other things and find their dysfunctional patterns. But the clock model, though, is simple and think, okay, well, I know where these are. In my mind, is if one of the first things I go to when I start to see these overuses is think, how do I flip these quadrants around so they can be functional and not create another problem? And I can take stress off the movement pattern that's going on. So same thing with, if it's probably radiologist, Ariel was saying, as she's doing that and dictating, it sounds like, or a pathologist, I need to kind of flip the model on her and make sure that, okay, she's doing this with the thumb. I need to change these patterns. What alternate muscle pattern can I give her? Put the list of muscles in here for you. I don't think we need to review a list of muscles, but it just gives you a general sense of direction and what we just talked about. And again, this article, they'll talk about the flexion and extension movements in the sagittal plane are being evenly distributed between the radiocarpal and midcarpal joints. This motion is occurring 50-50 between those two joints. I've seen different numbers on it. I've seen it where it's, more, proximal row and more radiocarpal. I'm not quite sure. What is your take when you talk about the distribution? Do you get into distribution of this motion, Eric?
Not too much.
Okay.
I think it
Mhm.
mechanically there's the occasion where it might make a difference as far as what you're trying to do treatment wise, but I think from a basic standpoint, I don't think it's going to cause too many issues. So if you look at it one way versus the other, so.
Yeah, but just kind of a nice way to see it. You look at the proximal row there again. You see those red lines. Those are the vectors of pull, and those vectors of pulls are essentially passing over that proximal carpal row. That proximal carpal row moving through the force of the distal pull and inserting distally. And this showing more again, by functional radial ulnar deviation. I like the idea of the dart thrower's motion. I always thought that was it because a lot of the functional position of the wrist, if you think about it, it's extension and radial deviation, flexion and ulnar deviation as we move into it. Now, much of what we do in many repetitive patterns follow that particular model. So that idea, that dart thrower motion, that arc is widely used in motions like, but they're in daily activities. So is that motion the component motion they're using? Are they using a different motion, which may be out of synergy? So understanding that dart thrower's motion, this being a very normal motion pattern of what we do. Or what I'll often see, if you see the wrist injury or a TFCC injury, is, it's the guy who's feeding tennis balls or throwing balls to his son because he doesn't have to throw it very far or very hard, so he can flick it. And I can do that dart thrower's motion repeatedly. But what happens there is then all the force is going usually into TFCC or the wrist. So you start to develop, some type of wrist pain or tendinopathy. You'll see it, but often you'll see it's okay. One is the dart thrower's motion. You'll see that'll be very provocative to it. Not that ulnar deviation won't be, but it's that movement pattern that they've emphasized where I've got to be more of a shoulder arc and elbow arc. Anybody seen any TFCC injuries with this type of movement pattern? Nope.
No, you guys can see one when we get to the class because I've got one.
Nice.
I've got a torn ligament here in my left wrist, and I can tell you guys all about it. But we'll give us a chance if you want to look at a couple of positive stress tests and things like that.
You're welcome.
And in here, I just put in with radial deviation. These are some of the carpal glides. Again, it goes into a little more detail. I put in there for you just so it'd be in there. I don't know if we want to get that level of detail right now. I just want to think about, as you can see, as this glides, it's what we're doing. We talk concave on convex proximal row on the radial ulnar joint or radial meniscoid joint, as we do in there. And the glide is going to be in the opposite direction of the movement. So with ulnar deviation, my carpal row is gliding laterally or toward my thumb. Does that make sense? Because it's a convex on concave motion as we do it. Again, it can be a little bit more complex because there's a bit of rotation that occurs into the carpal bones, but we'll save that for how deep Eric wants to go into it.
It's not terribly difficult, really.
Yeah.
You can tend to see it if you look at your hand from this side.
Mhm.
When you do radial deviation versus ulnar deviation, what happens distally in the hand. So
Mhm.
you don't necessarily need to memorize it. You can kind of just
Mhm.
watch it happen
Yeah.
hand as you move it.
Yeah, it would correspond to that dart thrower's motion that they talk about as well. You'll see that
Yep.
rotation.
100%.
They'll refer to in the article as pronation, supination. I think we'll refer to it as internal, maybe external rotation as you see it. Depending which joint axis we're talking
We can
about.
describe it both ways. It's not that
Yeah.
tough to notice.
Yeah, they're kind of the same thing as what I'm going to sense of. So we'll pick a certain language and go with it to keep it simple. Different models on risk because you're going to see all different ones, and so it's good to talk about them just because you know that okay, here are all the models you can look at. You have row theory, which is what we kind of talk about in front. Is that proximal row, distal row? Thinking about it. You have column theory, which will be mentioned. So you can have like a lateral, middle, and medial column. I believe is how they refer to it. You have row and column theory where they're kind of interspersed, and you can create different ones. And then the last one's going to be like a ring model, where the way these carpal bones all attach to the ligamentous system creates a functional ring. Move it. And I think, some of the notes I've seen, if you're teaching it the way Gail did, she kind of blended her models. Like she talked about model B, the column one, but then she also kind of looks at the joint mechanics. And the joint mechanics in the slide above follow more the ring model D. There's no consensus on this. So it's not like there's a one gold standard you need to know. I think it's just good to know that there are different models, that they exist, and how we move. We are going to assess the mobility and play in all of these joints and look at them. So what you're going to get is a lay of the entire land, not so much applying a model and taking it as Bible. You're going to be able to assess all the carpal motions, get to the root of the problem. It's going to be our goal. Just understand they do exist. They may be out there. So if they're referred to, you just understand that, okay, there's different ways of looking at the wrist. And you can palpate, think, oh, I'm going to palpate in a model that follows row theory. Or you can think, okay, I can palpate in a model that follows column theory. I don't know that it matters all that much, but I think for be thorough, it's good to include it in here. Talked a little bit about this earlier too. Load transmission through the wrist. Force transmits across the wrist in neutral form, position, rotation. Approximately 80% of the load is transmitted through the radial carpal joints. Approximately 45% of the force crosses the radioscaphoid joint, and 35% crosses radiolunate joint. The remaining 20% bears on the ulnocarpal joint. So again, we get ligamentous disruption. Bones are not, in their congruent position. You get increased force at a certain point on a bone that's not used to taking that force and breaking down. So let's say my triquetral hamate joint is taking 21% and I have something happen and now I have a focal point where it's taking 35%. That's where your joint breakdown occurs. So your wrist arthritis and your breakdowns, just like in the ankle, I think we talked about it too, is that if your subtalar joint is off axis, there are areas that are going to take more pressure than they normally do, and they will break down. So the wrist is kind of fairly similar. If I have an area here that's outside of this normal pressure distribution curve, that joint will break down, whether it's the lunate, the scaphoid, or the disc or triquetral. So assessing them, getting them mobilized, making sure they're moving well, is a great deal of importance when we look at it's degenerative breakdown. Because I found interesting, there was no significant differences when they looked at the loading mechanisms. They're only a few percentage points off in the different positions. Whether it's flexion, extension, pronation. Without anything to add on load transmission.
No, not really. I mean, I think when you look at it, you tend to think most often that you can end up putting more weight here on the lateral portion of your palm just because it seems like it's more convenient, but it's really not. It's really much more going through the radial side. Anatomically, I think the biggest issue with that is that when you look at the radius and how big the base of the radius is, the distal end of the radius is compared to the distal end of the ulna, you would expect that more load would have to be transmitted through the radius and thus through the scaphoid and the articulation of the lunate. I just, for whatever reason, I think there's a lot of almost like urban legend bias thinking that, oh, well, it's going to go through here. but it's not. I mean, that may just be kind of a false, faulty syllogism where you're kind of expecting something that's not real. But yeah, I mean, I think it's fine. It's why we tend to see more fractures in the radius, why we tend to see more fractures in the scaphoid, that sort of stuff. But when you think about it, if you have dysfunction then in the scaphoid, if the scaphoid is moved, if it's subluxed, if there's some sort of soft tissue lesion around it or an instability and how they'll be able to distribute those loads, then yeah, that's one of those things that makes a lot of sense. We should focus in on that area based on those numbers.
Yeah, if you have somebody working out, they're doing push-ups and they're getting wrist pain, then okay, understanding these loads becomes really important. Okay, if they're having, ulnarly sided wrist pain or TFCC pain, okay, what in the loading mechanism may be contributing to it? Looking at their loading mechanism, understanding it first is helpful.
Yeah. Or where they, say they slip and fall and they come down but they come down on the outside of their wrist here, right? So their weight lands on that outer portion, less capable of bearing those loads, right? So more likely to create some sort of lesion when that sort of thing happens.
And I know it's a lot of tedious language, something we probably haven't been studying too much over the years or looking at. It's not something there, but super helpful to kind of have this understanding this. And this is one of those things, once you get this, peripheral courts is so cool because they can add so much, like understanding these and the mechanics of it with your elbow patients, even shoulder patients, wrist patients. You'll get a lot out of it. You'll be able to do a lot. That's where, as I talk with Chan, if you're in a director position in a clinic or a regional guy, these things are super helpful, especially if you're even, talking to OTs. OTs generally won't look at the wrist the same way that you will in this course, so you will have a lot to add to them. And so it's not a knock on them. It's like, how do I bring this back and bring value to my group? Good. Okay, I added images in this time. Ariel, how did that work for you?
That was a lot better. Yeah, thank you.
Okay. Anything else that would make this easier or more helpful?
Separately, I was just trying to bring up and print some of the articles, and on the document that you sent, all the articles